was a perfect setup for me because it gave me some more time to think. Um, can we cue up this? There we go. So first of all, I just want to take the opportunity to say thank you to Emma and all of the GMN staff, all the providers and speakers who presented such wonderful content. Let's just give them a round of applause. Thank you so much. And thank you all for being here. It has been a very important exercise, I think, for all of us. And what I was asked to do was to just kind of go over some of what I think of as opportunities and challenges. So I went back to this picture, and this is a picture of Governor Nathan Deal signing the state budget that originally allocated funding for the Georgia Alzheimer's Project, which subsequently became Georgia MemoryNet. And it always gives me a little chuckle when I am at national meetings and I can talk to my colleagues from Massachusetts or California and say, you know, thanks to the incredibly forward-thinking and progressive Georgia State Assembly, we have this incredible statewide network of dementia evaluation and care. And yes, I say that being a little bit sort of tongue-in-cheek about the political environment in different locations. But the truth is, you know, I don't really care if our representatives are in the House and the Senate or in governmental offices are Republicans or Democrats or Libertarians or Communists. Well, or well, maybe not fascists. We can do without fascists. But this is something that people of goodwill, Jack Hill, who is the gentleman to Governor Deal's left, and Terry England were each chairs of the Senate and House Appropriations Committees. Especially Terry England is in my mind one of the heroes for our state and for Georgia MemoryNet, and for advocating for improving care for our patients and families around the state. And they recognize this need because each one of them was touched personally by Alzheimer's and dementia in their families. And so it doesn't care what your political leanings are. It doesn't care if you're wealthy or poor, if you're black or white. And so this is a universal problem, and we have this incredible opportunity in this state because of forward-thinking individuals who had the vision to choose to invest. And then in 2022, because of all of the work that you all have done as part of Georgia MemoryNet, the State Assembly increased our budget by another $3 million and then allocated additional funds for DAS to implement the dementia care specialists in the AAA. So continued support for this initiative across government. And it gives us really a unique opportunity to lead the nation. And literally, we are leading the nation. So some of our Georgia MemoryNet leadership published a paper in the Journal of the American Geriatric Society describing what we were doing. And even before then, we've been contacted by other states wanting to know how they could replicate what we've done here in Georgia. So it literally is leading the nation. And I think we should take a moment just to be aware of that and to be proud of what we're doing here in the state of Georgia. Now, this is just a rehashing of some of the primary goals of Georgia MemoryNet. And this one to improve access to services and support and education. This is to serve the immediate needs of those patients, those persons living with dementia and their caregivers who have immediate needs for support now that's not being delivered, that's going to help support aging in place and help them avoid some of the unnecessary sort of disasters and challenges that they might confront. And so this is what we're building with our partners to provide access to community services, links to AAAs and the Alzheimer's Association, and providing sort of care assessments, care needs assessments, and care planning. And then the development of the memory assessment clinics, and then the engagement with primary care providers to promote early recognition. This is really designed to allow us to take advantage of the advances that are happening right now in the improved opportunities to provide improved care and better disease management for patients. And so these are our primary sort of goals and things that we're continuing to work on and things that we still have challenges. There was one other thing, though. This three-legged stool is really a four-legged stool, and I always kind of omit this. One of the other explicit goals of the Georgia MemoryNet and the legislation and the budget and the contracting with the state is this very robust IT infrastructure. And this is more applicable currently to our Georgia MemoryNet memory assessment clinic locations, and not as much, although I think it may become more useful for our primary care providers across the state. But I want to just tell you why this is so important. So many states have invested previously in dementia care, evaluation, and so on. Florida's done it, Wisconsin's done it, California's done it. What we've done that's unique across our network is that there is this consistent infrastructure that captures consistent data across all of our memory assessment clinics. So if you are seen at a MAC at Grady, or you're seen at the MAC at Macon, or you're seen at the MAC in Albany, you're going to get the same cognitive assessment, you're going to get the same functional evaluations, you're going to get the same care planning, same linkages to AAAs and AAs. It's going to happen uniformly across the entire state. That's unique, and that rests on the backbone of what we call the GMN portal. And this is something that's given us another opportunity. So we haven't spent a lot of time in the weeds about the monoclonal antibody therapeutics, but there was something called coverage with evidence development that CMS released in describing what their expectation was in providing Medicare coverage for anti-amyloid monoclonal antibodies. And among those was a requirement that people who are getting treated with these anti-amyloid monoclonal antibodies have their data captured in some form of registry that will allow us to understand the questions that many of you have about these drugs. What is the benefit of these drugs? Who benefits from them? Do the benefits outweigh the risks? And these are questions that are a requirement for CMS coverage. And I will tell you that what CMS did in first approving coverage, they developed a registry, a monoclonal antibody registry that was created by CMS and made available. It went live the same day that FDA gave standard approval and CMS approved coverage. And it is woefully inadequate to meet the goals of the coverage with evidence development. So if any of you ever go and register your patient for treatment for coverage from Medicare for these drugs, you can go to a website. They will ask you questions about what biomarker was used to confirm that individual had Alzheimer's disease, what their MoCA score was, or MMSE score was, or CDR was, what their FAQ or their other functional score was, and what date that was. They will ask you if they're on antiplatelet agents or anticoagulation, if there's evidence of ARIA on imaging, and that's it. And I think that when you are required to go in by some Medicare Advantage plans, where I know you guys were laughing at me, I didn't know what Medicare Advantage was, but when those Medicare Advantage plans make you go in sometimes and re-register every 6 months, is the same thing. There is nowhere, they do ask that question about was there ARIA. There are no details. When was it? Was it before the 3rd dose, 5th dose, 7th dose, 14th dose? Was it ARIA-E? Was it ARIA-H? How old was the patient? I guess Medicare would have that data based on Medicare data. But they don't ask any of that, right? So they provided access to these drugs, and they've simplified it, but their registry is inadequate to provide the information to answer the questions that you all have. What is the expected benefit for these individuals? Who's going to benefit the most? Who's at greatest risk? And so we created what was really, there was a random registry that came out of Boston, but this was really the first CMS-approved anti-amyloid monoclonal antibody registry that was approved by CMS and registered with clinicaltrials.gov in the country. There's one other one that has been approved now from the Alzheimer's Association in collaboration with AltsNet. But we have designed this to work on the back of the Georgia MemoryNet portal, the GMN portal, because we capture the same data in our evaluations, in our routine evaluations, that we want to have in order to track the responses, clinical responses, the functional abilities of individuals, and then also have implemented within the GMN portal for those individuals who are getting anti-amyloid monoclonal antibodies, whether they've developed ARIA, whether treatment had to be paused, all of those relevant details to track the actual use and benefit and risk of these drugs in clinical practice. And so that's something that is, we think, a really incredible opportunity to do this using the GMN portal to collect longitudinal data that will allow us to help our colleagues everywhere understand what the actual experience is based on data that's highly reliable. I think there are probably some other institutions that are doing this, capturing their data locally, but this is the one of four actual approved protocols through which you can get Medicare and insurance coverage for these treatments. So an important thing to remember as we think about what we can do with GMN portal. And then I put this slide back up. You saw this yesterday because this is something that I've been sort of ruminating on, and as Ted was taking us through this exercise, thinking about what the current challenges are. So our most acute current challenge is what we've been talking about, how to do this. And so I just did some, back of the napkin tab pad calculations. So the estimates currently are there are about 130,000 Georgians with Alzheimer's disease. And we don't know how many of those would be eligible for treatment with these disease-modifying therapies, but let's just say it's 20% of them. That means there are 26,000 Georgians who potentially could benefit from these disease-modifying therapies. Well, how the hell are we going to do that? And that was the challenge that insight that I wrote down. We need to figure out how to support providers who are going to prescribe these disease-modifying therapies. And 26,000 people, how the hell are we going to do that? So there are several things that I think we can do and to try and tackle this problem. We're not going to be able to have sort of, even with facilitated referral processes, we're not going to be able to do this and absorb it among neurologists or cognitive neurologists or practicing neurologists who are comfortable and willing to prescribe these drugs. It's going to have to be a much broader pool of providers who decide, yes, this is something that I think is a good idea for my patient and I want to prescribe it. But we have to figure out how to support that. The challenge is going to be developing a consistent approach across the state, because we're talking about right now 7 different memory assessment clinic sites, but then if we talk about other providers prescribing these drugs in different practice settings, different health systems, how are we going to support that? The inconsistency in the radiology expertise in terms of safety monitoring is a key one. There are some solutions. I don't know if this actually came up during one of the presentations, but there are some options in terms of new tools that are being developed using AI that will automate the detection of ARIA and other abnormalities that could be automatically flagged. And most of the time that's going to be no, there isn't anything, but we have to anticipate about 25% of these individuals are going to develop some ARIA at some point. And so if you get a report and you're tracking it and it's negative and it's safe, it's cool, but then what do you do if there's it's not so cool, or it's a major problem? We have to figure out how to support that process. So one thing, and the second part of Ted's exercise, one of the things that I thought we might be able to do as one of the steps is to actually contract by GMN with these companies that have developed these AI tools and make that system available and accessible through Georgia MemoryNet. So we've already gone through the process of establishing contract with Piedmont, with Northeast Georgia Medical Center, with B.B. Putney, with Navicent, with Meadows. So multiple health systems, we've sort of had that experience, and so maybe we can do that and make that one of the mechanisms that we can use to at least knock down one of those key barriers, the safety monitoring, and then other systems to provide consultation for when people are having problems, so that you're not out there flapping in the breeze by yourself. If a patient has a problem, you have a source for backup and consultation about, well, is this a good time to pause the treatment? Do we need to just stop altogether? Some places have implemented case conferences to review patients that may be good candidates, and so reviewing those with others to get some input and advice on how to do some of those things. But I think we have to tackle that. There's no way we're going to be able to. This is the whole reason we built Georgia MemoryNet, was to be able to deliver these treatments to to Georgians in a more timely manner. And we have to overcome this. It came faster than we expected, but we have to overcome this, or all the work that we have done, it's not for naught, but it is not going to deliver the potential advantages and advances for Georgia and for our patients and families that it could have, to avoid that suffering and late-stage disease that we want to avoid. And then this is, I made this for the summit that we had earlier this summer in terms of next steps. And so this is, and the numbers are a little bit different from what I just cited, but the bigger problem is what I alluded to yesterday. What happens when we can do secondary prevention? Because now the numbers aren't 6,000 or 13,000 or 26,000. Now, the number of people who might benefit from treatment in the state of Georgia, if you identify people who have asymptomatic pathology between the age of 50 and 70, maybe 200,000. And we may need to figure out how to screen 2.5 million Georgians. And so when I think about GMN Part 2 or Part 3 or whatever part we come up to, this is the challenge that we're going to have to confront in the next 5 years, 10 years, because that's where the space is going. That's where the Alzheimer's treatment is going, to prevention, and that will be the ultimate goal. And so if we can't figure out how to deliver treatment to a few thousand people today, we're going to have one hell of a time figuring out how to deliver treatment to potentially 250,000 people tomorrow. So just something, you know, not to get daunted. I don't want, it's a little daunting, but I think that it's important to kind of think ahead, because think how great that is. I mean, how awesome is that we're talking about how are we going to do this so that we can prevent Alzheimer's disease in 200,000 people? I mean, that's just unbelievable. And so it is a mountainous task to overcome. But I think that it's something that really we as a group, as a state, as people anywhere, it's a task certainly worth trying our best to tackle. So thank you all so much for being here. We look forward to continuing our work with you, our collaborations with you, and to continue to grow and develop this network so that we can reach these goals that we share in common. And thank you very much, and I hope to see you again very, very soon.
Great. Thank you, Dr. La. So we have come to the end of the PCP Symposium. Again, thank you all so much. Dr. La did a great closing statement. So right now is the evaluation section. So on your tables are the QR code, is the QR code. You can scan that and please complete it to get the evaluation. It's also on the agenda, so if you happen to miss it, please scan it and do so. Yes, please. We do? Is it Heather?
And Sheila is a friend who happens to be a lobbyist, and I always say the lobbyists get a bad name. But Sheila's mother suffered from early onset Alzheimer's disease, and she also received care at Emory, and she was one of our real advocates and champions, and she and Terry England really worked very closely. We also have governmental relations people, lobbyists from Emory and other health systems that are involved in helping to support. And then the Alzheimer's Association has always been a supportive partner and other advocacy groups.
Thank you. Any other questions? Yes. And so that will come in via email within the next week or so. Let's do 2 weeks to be on the safe side. Okay, very good. Thank you so much. I do want to acknowledge 2 people who were tremendous in putting this together and helping us today, Rosie Rogers and Stacy Rowland, for helping with registration, setting up, putting up signs, and just making this task easier, and the entire planning committee for making this a true success. Thank you, and you for coming here, making it a true success. Thank you so much. We have boxed lunches for you. Please grab one on your way out, and safe travels. We'll see you on email, Zoom, or somewhere virtual and in person soon. Bye-bye.